for long. My topic is to study the RNF layer thickness in various grades of myopia. So as we all know that RNF is it's a crucial biomarker in the assessment of ocular health, and particularly in diseases such as glaucoma and myopia. As the entities sometimes overlap, so it is essential to study the RNFL thickness in various sectors to differentiate glaucomatous damage from the myopic damage. So this study was conducted in our institute, that is RIO-PGMS Rohtak, in which 208 eyes were analyzed, and patients were categorized into 4 groups according to this grades of myopia. Group 1 was mild myopia, less than 3 diopters, and 52 eyes were taken. Group 2, moderate, 54 eyes were taken, 3 to 6 diopters. Group 3, more than 6 diopters, and 52 eyes were taken. Group 4 was a control group in which the patients were, there were normal eyes, 50 eyes were taken in that. Exclusion criteria, all those cases in which the RNFL thickness is reduced, they were excluded, like glaucoma, diabetes, trauma, hazy corneas, because we cannot take a good scan on that, and other diseases, so we did not take that. Now, coming to the demographic profile, we know that majority of the patients were aged between 18 to 30 years of age, although we took from 18 to 50. There was no significant age or gender differentiation, and most of the participants were students, approximately 50%. Coming on to the observations, we came that axial length and myopia, we know that axial length correlated with myopia severity directly. High myopia group had 100% of the eyes with axial length more than 25 millimeters. Significant correlation between axial length and RNFL thinning was found. Fundus changes, as we all expect, higher degrees of myopia is associated with more fundus abnormalities. More than 50% of high myopia cases had moderate tessellations and peripapillary atrophy. There was a significant difference in fundus changes across all the groups. Now, the basic purpose of this study was to study the RNFL thickness. Now, RNFL thinning was most marked in superior-nasal and inferior-nasal sectors or the quadrants. Now, these are the quadrants in which superior and inferior we have found that the thinning is there in glaucoma also. So we could, but they are more in supratemporal, infratemporal. Here it was supranasal, infranasal, and the least affected was the temporal lower quadrant. Higher myopia was linked with greater RNFL thinning, and every 1 millimeter of increase in size in axial length led to a thinning of average 3.87 microns. So as you can see in this picture, in this table, supranasal was the most commonly affected and most severely affected, and temporal lower quadrant was the least affected. Intraocular pressure was highest, surprisingly, in mild myopia group, which was mean was 13.31. Control group had the lowest, that was 11.52, and there was a significant difference between the groups. To summarize my study, the myopia severity affects the RNFL thickness, axial length, and the fundal changes. High myopia is associated with significant RNFL thinning. Supranasal and temporal lower quadrants are, supranasal is the most, had the maximum thinning, while temporal lower had the least thinning. Axial length and RNFL thickness have a strong inverse correlation, and further studies are needed to evaluate long-term effects. Now, the clinical implication of this is that optical coherence tomography must be interpreted with caution in high myopes, as false positive RNFL thinning can occur. Looking at the optic disc morphology, along with RNFL thickness and visual field correlation, helps to differentiate between myopic and the glaucomatous patients. And additional tests like GCC and intraocular pressure monitoring with visual field progression will help confirm the diagnosis. Thank you so much.